and also in Paget's disease. Children commonly sustain a green stick fracture of their long bones. This occurs when one cortex of the bone is intact or damaged. In children, displacement of an epiphysis may lead to growth disturbances. This illustrates a transverse fracture due to a transverse force. Also seen is an oblique or spiral fracture caused by a twisting force. Also a crush fracture due to direct trauma. The healing of fractures progresses from initial hematoma formation to granulation tissue, neither of which can be seen on standard X-rays. This is followed by callus formation, lamellar bone, and final remodeling, all of which are radio-opaque. Oblique fractures heal in approximately half the time of transverse fractures, while children's fractures heal much more rapidly than fractures in adults. Many other factors, however, play a part in the healing of fractures. These include the presence of infection, the blood supply of the bone, and adequate immobilization. Complications of fractures in children include overgrowth or shortening, angulation of the fracture, avascular necrosis, especially of the hip, and growth disturbances due to epiphyseal damage. If the epiphysis, especially around the elbow and knee, is partly damaged, continued growth on the uninjured side may gradually result in a varus or a valgus elbow or in knee angulation. Cubitus valgus deformity in this girl was due to a fracture of the lower humerus 3 years previously. This gradually increased due to damage of the lateral side of the lower epiphysis, with continued growth on the medial side. This resulted in a late or tardy ulnar nerve palsy due to stretching of the nerve over the medial humeral condyle. Common fractures in the elderly are illustrated. They include Colles fracture and fractures of the neck of the humerus due to falls on the outstretched hand, and fractures of the hip. They're due to falls in patients with osteoporotic bones. In the elderly, fractures of the hip should be operated on, if possible, on the day of admission to hospital. These patients should be mobilized full weight bearing and sent out of hospital within a few days of operation. Falls from a height are common in those who work from ladders, such as painters, window cleaners, and builders. They may fracture the calcaneus with associated fractures, particularly of the lumbar spine. They may also sustain a central dislocation of the hip. This elderly patient demonstrates the dangers of putting an old patient to bed for a long period. Complications include, in the lower limbs, bed sores, lower limb flexion contractures, and deep vein thrombosis with pulmonary embolus. They also include urinary retention with cystitis and ascending pyelitis and pyelonephritis, as well as bronchopneumonia and mental confusion. These complications are the main reason for early mobility and the return of the elderly patient to home or nursing home as soon as possible following injury. The common peripheral nerve injuries are illustrated. These include in the upper limb damage to the axillary nerve from fractures of the neck of the humerus and dislocations of the shoulder. Fractures of the midshaft of the humerus may cause a radial nerve palsy, fractures of the medial epicondyle and ulnar nerve palsy, and dislocations of the lunate, a median nerve palsy. In the lower limb, a posterior dislocation of the hip and a vertical force fracture dislocation of the pelvis may cause a sciatic nerve palsy. A dislocated knee may damage the common perineal nerve as well as the popliteal vessels. The typical appearance of an ulnar nerve palsy with partial clawing of the fourth and fifth fingers. A median nerve palsy due to a wound on the palmar aspect of the wrist. This is causing wasting and paralysis of the thenar muscles. A wrist drop due to a radial nerve palsy. In this case it was a so-called crutch palsy due to crutches which were too long for the patient, causing pressure in his axillae with resulting paralysis. Other common causes of radial nerve palsy are a fracture of the mid-shaft of the humerus with damage to the nerve in the spiral groove. The third common cause is a so-called Saturday night palsy. The drunken patient falls asleep with his or her arm over the back of an armchair or sofa. This results again on pressure over the radial nerve in the spiral groove of the humerus. Over 80% of these closed radial nerve palsies luckily recover with splinting of the wrist drop and without the necessity for an operation. Pathological fractures due to a secondary deposit in the mid-shaft of the humerus, as illustrated, will require early operative internal fixation followed by radiotherapy. The suturing of lacerations and the method of closing wounds is illustrated. It must be stressed that dirty wounds must be left open after adequate debridement and only closed by secondary suture due to the danger of infection. Plaster of Paris is the cheapest and easiest method of holding an unstable fracture after closed reduction. This shows a plaster back slab used to hold the reduction of a Colles fracture. The scalicast is a concept designed by the author in 1966 and is a lightweight method of immobilization of fractures by waterproof struts where manipulation is not required. The easiest method of application is by the use of thermoplastics dipped into hot water and applied directly onto the patient over waterproof padding. The scaphoid scalicast, shown here, is the ideal lightweight type of support. This is because scaphoid fractures do not usually require prior manipulation. This scalicast support weighs about 1/7 of the weight of plaster Paris. Fractures immobilized in a scalicast have been found to heal more quickly than when held with hot, heavy, complete plaster encasement. A knee hinge can be easily added to allow the knee to bend, as illustrated. Patients can shower and swim within a few minutes of application of the scalicast. Struts can be easily tightened, loosened, or adjusted if required. Wounds can be viewed through the scalicast as shown. Radiotherapy can be given if required, and edema controlled if necessary by wool and a crepe bandage over the scalicast. Polyester resin paste, as used for car and house repairs, and impregnated into fiberglass tape or bandage can be used instead of thermoplastic. It is much cheaper but takes longer to apply and is messier. Longitudinal struts are covered aluminium or wire. Introduction to upper limb injuries. A patient with a scaphoid fracture surfing on Maroubra Beach in Sydney within an hour of his scaphoid scalicast being applied. Dislocations of the proximal interphalangeal joint are common and can usually be easily reduced in adults without an anesthetic. A prior X-ray should be taken to ensure that there is no associated fracture. Strapping should be attached to the distal part of the finger before manipulation in order that the surgeon can obtain a good grip on the finger. The patient should be warned to expect a sharp pain when traction is applied. An assistant should hold the rest of the hand while traction followed by flexion of the finger is applied. In nervous patients, in children, and when the dislocation has been present for more than 6 hours, local anesthetic should be used. The anesthetic again should be used without adrenaline. It should be injected into the base of the finger on each side of the relevant metacarpophalangeal joint. Adrenaline must never be injected due to the danger of spasm of the digital arteries and possible danger of peripheral gangrene, as shown here. Following reduction of the dislocation, the finger should be immobilized in a short aluminium front splint, as shown, for 3 weeks. This is followed by strapping of the joint to minimize the edema, which may be troublesome. The same splint can be used for fractures of the middle and distal phalanges after manipulation under anesthetic if necessary. Internal fixation is rarely necessary. In dislocations of the proximal interphalangeal joint, fractures of the proximal phalanx, and of the distal metacarpal neck, this splint should extend into the palm as shown. It is again left for 3 weeks. In wounds of the palmar aspects of the fingers, apart from possible damage to the digital nerves and vessels, it is important to examine for possible division of the flexor tendons. The little finger illustrated could have sustained division of both flexor profundus and superficialis. The deep wound to the ring finger, on the other hand, would have only divided flexor profundus. On examination of this finger, this boutonniere or buttonhole deformity of the proximal interphalangeal joints is shown. This is due to rupture of the extensor muscle insertion into the base of the middle phalanx and is common in severe rheumatoid arthritis. On careful inspection, however, there is no other evidence of rheumatoid arthritis of the metacarpophalangeal or the proximal interphalangeal joints. This deformity is not due to rheumatoid arthritis, but is a rupture of the insertion of the middle slip of the extensor tendon into the middle phalanx due to trauma. The lateral slips of the extensor tendon, which are inserted into the base of the distal phalanx, have been spared. They have slipped on each side of the proximal phalanx and are overacting and causing the distal phalanx to hyperextend. Severe bruising and swelling over the dorsum of the hand is shown. This is due to a fracture of the metacarpal. This oblique fracture of the midshaft of the third metacarpal is being adequately splinted by the other metacarpals. This only required a simple aluminium splint as shown for 3 weeks. The alternative would be a crepe bandage or strapping. Fractures of the neck of the metacarpal usually have an anterior angulation of 30 degrees or less. They merely require a simple aluminium splint extending into the palm for 3 weeks, as already illustrated. Severe fractures with displacement, as shown, should be treated if possible with internal fixation with small plates or intramedullary nails. Dislocation of the metacarpophalangeal joint, as shown, requires reduction under anesthetic. This dislocation may, however, buttonhole through the capsule of the joint and require open reduction. Occasionally, the flexor tendon is also ruptured. A fracture dislocation into the base of the carpo-metacarpal joint is called a Bennett's fracture dislocation. In view of the importance of this joint, it must be accurately reduced. It is then held in plaster with the thumb fully adducted, with the plaster extending up to the interphalangeal joint. Alternatively, If a perfect reduction cannot be obtained by closed reduction, the fracture should be accurately internally fixed with either a wire or a small screw. Falls on the outstretched hand may cause a variety of injuries as illustrated. These include fractures of the scaphoid and anterior dislocation of the lunate in young patients, and Colles fracture common in elderly patients. Fractures of the shaft of the radius and ulnar and of the head of the radius. Supracondylar fractures are common in children. Fractures of the neck of the humerus are common in elderly patients. Anterior dislocation of the shoulder and fracture of the clavicle are commoner in younger patients. This is the typical dinner fork deformity of a Colles fracture and is the commonest fracture in elderly women. The displacement of the lower end of the radius is threefold. This is backward displacement, backward rotation, and radial displacement. In addition, the fracture is usually impacted, and in addition also, this is often associated with an unimportant fracture of the ulnar styloid. This drawing illustrates the backward displacement and rotation and the radial deviation of the lower radius in a Colles fracture. Manipulation of the fracture under anesthetic should include initial traction in pronation. This is to disimpact the fracture. This is followed by forward rotation and palmar flexion, followed by ulnar deviation of the fracture. Following reduction, a plaster padded below elbow back slab is applied for a week until the edema has settled, plus a sling. This is followed by completion of the plaster for further 5 weeks. In most cases, the wrist should not be palmar flexed, but held in neutral rotation. Only in very severe fractures is it necessary to palmar flex the wrist. In addition, and only very occasionally, is an above elbow plaster necessary with the wrist held in pronation. The danger of palmar flexing the wrist, especially in elderly patients, is stiffness of the metacarpophalangeal joints. Fractures of the scaphoid are common, especially in young patients. Fractures of the waist of the scaphoid and proximal pole are particularly liable to progress to non-union or even avascular necrosis of the proximal pole. This is because the blood supply may be cut off, as this enters the scaphoid from the distal part of the scaphoid. The patient should be examined for tenderness in the anatomical snuff box and for tenderness on proximal pressure on the second and third metacarpals. It is important to make a provisional diagnosis at the time the patient is first seen. If no fracture is seen on initial X-ray, the patient should be treated as a fracture for 3 weeks on suspicion. A scaphoid plaster or an aluminium cock-up splint should be used for 3 weeks, followed by another X-ray. If there is still doubt, a nuclear bone scan will confirm an associated fracture. X-rays should also include oblique X-rays of the wrist as well as AP and lateral. This shows an undisplaced oblique fracture of the waist of the scaphoid. This is the standard complete wrap scaphoid plaster of Paris or thermoplastic. The wrist and thumb are held in a position that they would normally take in writing with a pen. This support is usually left in place for 8 to 12 weeks. A scaphoid scalicast is shown. It is a much lighter waterproof method of holding a scaphoid fracture. The support is usually made out of thermoplastic struts, as already described. Full details on the application of scalicasts is described in A Simple Guide to Trauma by the author. It has also been found that fractures unite more quickly in a scalicast than when immobilized by complete encasement in plaster or plastic. In addition, check X-rays can be carried out without removing the support. In patients where there is displacement of a scaphoid fracture as illustrated, internal fixation of the fracture should be carried out. This is also important when the lunate is dislocated with half the scaphoid, a so-called Trans-Scaphoid Periluna fracture dislocation. The best method of internal fixation is by the Herbert variable pitch screw fixation. This is a screw with a smooth shank as shown, with threads with a different pitch at each end. The screw was developed in the orthos department 20 years ago by Dr. Tim Herbert. These diagrams illustrate how the screw will compress a fracture as a smaller diameter distal screw with the increased distance between each thread will advance more into the bone at the far end of the fracture than will the larger diameter proximal thread of the screw, which has threads closer together. This will result in the fracture being compressed as the threads of different pitches act independently on the two fragments of the scaphoid fracture. This X-ray illustrates a Trans-Scaphoid Periluna fracture dislocation.